Right. Welcome you all to the Satellite Symposium, Complex PCI and Master DAPT, organized by CVRF and supported by educational grant from Terumo. Actually, this year's TCTAP meeting is also virtual. So I really want you all enjoy as our meeting. Right. I am very happy and honored to have distinguished two speakers, Do-Yun Kang and Fazla Malik from Bangladesh. And uh, as a panelist is Jo Yun Young and Pham Jian Ming and Dr. Lee Sung Woo here. So, right. So we're gonna start the first talk, the real-world performance of Ultima Stand data from the IRIS Ultima registry. Please, Dr. Kang, please.
Thank you for your kind introduction, Dr. Park. I'm Dr. Do-Yun Kang from Asan Medical Center. Today, I will talk about the real-world performance of Ultimaster stent with the data from IRIS. The Ultimaster stent is a biodegradable polymer sirolimus eluting stent in BPSCS, and it is Terumo's second BPSCS with a thin strut flexible design. And it was launched in 2014, and now newer Tansei version is on sale. It has the cobalt chromium platform with a thin strut of the thickness 80 micrometer. And it has the design of the open cell with a 2-link and 8 crown. The left side is the design of the 2.25 to 3 millimeter stent, and the right side is the bigger stent design. And the Ultimaster stent with a 2.25 to 3.0 stent can be expanded up to 4.5 millimeter. The expandability is very good. And the 3.5 to 4.0 millimeter diameter stent can be expanded up to 5.5 millimeter, very large expandability. And it has the drug with the sirolimus with a polymer bioresorbable polylactic acid copolymer. So the polymer degrades at 3 to 4 months after stenting, and the stent thrombosis risk would be low after drug polymer degradation. And it also has the abluminal gradient coating with the abluminal polymer and drug coating, so it minimizes the risk of the stent thrombosis. The Ultimaster stent has been studied worldwide by enrolling over 50,000 patients in Terumo-sponsored trials and other many investigator-sponsored research. One good example is the Master DAPT, and Dr. Malik will thoroughly review the result of the Master DAPT trial in next lecture. And in this lecture, I will talk about our IRIS Ultimaster registry in detail. This is investigator-initiated research with the Terumo, the sponsor. And this is a prospective multi-center real-world registry with all consecutive patients who underwent PCI with Ultimaster stent in 15 academic centers in South Korea. And it enrolled the patient from 2016 to 2019 for 3 years. And the patient who implanted other drug-eluting stents or cardiogenic shock or life expectancy less than 1 year were excluded. And patients were followed clinically at 1, 6, 12 months and every 6 months thereafter. No routine angiographic follow-up was performed. And the primary outcome of the registry was the target vessel failure that was defined as a composite of a cardiac death, target vessel myocardial infarction, and target vessel revascularization at 1 year after PCI. And in this analysis, the clinical outcomes of the patient in IRIS Ultimaster stent with the 663 patients were compared with the DPES in IRIS-DS registry. The DPES means the durable polymer everolimus eluting stent with a giant stent. And the patient in the more than 600 patients with a compared with the historic 1,235 patients with giant stent. And the adjusted outcome was compared with the use of propensity score matching. This is the result of the overall population. In Ultimaster patient, the patient age was 65 in average, and 74% of the patient was male patient. And about more than half of the patient was underwent PCI because of the acute coronary syndrome, and about 14% of the patient had a history of PCI, 13% of diabetes, and 60% of the hypertension, and 30% of the current smoker. That means very average population who underwent PCI with a high rate of the acute coronary syndrome. And 2% of the patient had chronic kidney disease. And when compared with the Giants group, the more patients with acute coronary syndrome, patient underwent Ultimaster stenting. And disease extent, one vessel disease was more than half, and about 5% of patients has the left main PCI. And about 1/3 of the patient has the bifurcation lesion. And 13% of the patient underwent emergent procedure, and about 40% of the patient underwent PCI with IVUS. And about 1.5 stent was implanted in average, and total stent length was 31, and average stent diameter was 3.2 millimeter. And aspirin was prescribed in almost patient, and clopidogrel in 70%, and ticagrelor or prasugrel in 30%. And statin was prescribed in 96% in discharge. This shows an average detail of the PCI in Korea. And when compared with the giant stenting group, the less left main involvement and less bifurcation involvement was shown. And this is 1-year clinical outcomes in overall population. The giants after Ultimaster stenting, when compared with the giants group, the target vessel failure was 4.4% after 1 year, and lower than DPES group in overall population. And no cardiac death was reported at 1 year, and 3.2% of the target vessel myocardial infarction, and TVR at 1.4% at 1 year was reported. And stent thrombosis was occurred just in one patient, a very low rate. And then we performed the propensity matching to adjust the difference in baseline patient and characteristic details between two groups. And all variables was well matched after propensity score matching. Also, the lesion characteristics and procedural characteristics was well matched after matching. And there was some difference in discharge medication, but it was not matched because it is not baseline characteristics. And this is 1-year clinical outcomes in propensity score matched population. Even in matched population, Ultimaster stent showed very good clinical result with the target vessel failure rate 4.7%, and TVR rate 1.5%, TLR rate 1.0%, and stent thrombosis rate 0.2% at 1 year after stenting. And it was comparable with the historic comparator of the DPES stent. In conclusion, the patient underwent PCI with Ultimaster stent showed lower target vessel failure rate at 1 year compared with DPES population in IRIS-DS registry. And Also, Ultimester showed comparable clinical outcomes with DPES even after comprehensive statistical adjustment. So in conclusion, IRIS Ultimester registry proved the excellent real-world efficacy and safety of the Ultimester stent. Now, the Ultimester has the newer version with a minor change with the Ultimester Tansei. It improved delivery catheter, and we are enrolling patients since 2020 September in 11 centers in Korea with all common patients with iris Tansei, with the Tansei stenting. Thank you for your attention.
Okay, great. Nice presentation, some nice, rich data. We want to move second speaker, Dr. Fazila Malik. He will give us a master DAPT study design and clinical findings. Please, Dr. Malik, please.
Friends and colleagues, it's indeed a great honor and privilege for me to be presenting the results of the Master DAPT trial on behalf of all the investigators. As you might be aware, this was initially presented in ESC 2021 by Professor Marco Vajmili. Now, this study was undertaken in a group of high bleeding risk patients who had been treated with a drug-eluting stent, and the aim of the study was to see whether an abbreviated DAPT regimen mitigated their bleeding risk without in any way compromising their safety or increasing their ischemic burden. This study was undertaken in 140 sites in 30 countries and spanning 4 continents. So a truly global study, and the patients were all high bleeding risk. They were treated with the Ultimaster stent with no restriction on clinical presentation or PCI complexity. And 1 to 1.5 months after the PCI procedure, provided that the patients were free from any active bleeding, were free from any cardiac and cerebral ischemic events, and no further revascularization was being planned, were randomized either into the abbreviated DAPT group or the standard DAPT group. In the abbreviated DAPT regimen, immediately the dual antiplatelet was discontinued, and the patient was followed by a single antiplatelet for 11 months or for 5 months if an oral anticoagulant was indicated. And in case of the standard DAPT arm, the patients continued with the dual antiplatelet for 2 or 5 months, depending on whether the patient was on or without an oral anticoagulant, and after that, followed by a single antiplatelet for 11 months. And the patients were deemed high bleeding risk if they had one of the following criteria, or if their precise DAPT score was more than 25. And the patients were excluded from the study if they had been ever treated with a bioabsorbable scaffold, or they were being treated for in-stent restenosis or stent thrombosis, or if the patient had been treated with any stent other than the Ultimaster stent at the index PCI procedure or within the last 6 months. The Ultimaster stent was chosen for this study because it already had a CE mark for 1 month DAPT. And this study, interestingly, had 3 primary endpoints which were tested in a hierarchical order. Now, the first point to be tested was the net adverse clinical events, which was NACE, the composite of all-cause death, MI, stroke, and major bleeding, defined as BARC type 3 or type 5. After this, the major adverse cardiac and cerebral events was tested, the composite of all-cause death, MI, and stroke. The first 2 primary endpoints were tested on a non-inferiority basis in the per protocol population. And only when non-inferiority was met for both these endpoints, the third primary endpoint was tested on a superiority basis in the intention to treat population. And the third primary endpoint was major or clinically relevant non-major bleeding, the composite of BARC type 2, 3, and 5 bleeding. And the patients were studied up to 335 days after the index PCI. Now, if we look at the patient distribution, a total of 4,579 patients were eventually randomized either to the abbreviated DAPT group or the standard DAPT group, and they were followed up for 1 year. If we look at the baseline characteristics of these patients were truly high-risk population, and they had at least 2 or more than 2 high bleeding risk criteria. The vast majority of the patients were elderly, the average age being 76 years. Diabetes was present in around 30% of the patients. Around 18% of the patients had prior MI. Atrial fibrillation was present in around 32% of the patients. Around 35% of the patients were on oral anticoagulants. And regarding the clinical presentation of the patients, 50% of the patients came with chronic coronary syndrome, and the other 50% came with acute coronary syndrome, including ST segment elevation, myocardial infarction. If we look at the procedural characteristics, the vast majority of the procedures were done through the radial route. Multivessel PCI was done in 25% of the patients. Left main PCI was undertaken in around 5.5% of the cases. According to the AHA classification, in 68% of the cases, it was a complex lesion. Number of stents per patient was around 1.7. Total length of stent in an average patient was around 39 millimeters, and overlapping stenting was done in around 21% of the cases. And bifurcation stenting was undertaken in around 4% of the cases. And in all these cases, the patients were given the bioabsorbable polymer sirolimus eluting Ultimaster stent. Regarding the dual antiplatelet duration, for the abbreviated DAPT regimen, it was 34 days, and for the standard DAPT regimen, it was 193 days. And after that, the single antiplatelet which was given to the patients dependent upon the investigator's choice. If we look at the clinical events, if we look at the net adverse clinical event, we see that in the standard DAPT arm, it was 7.7. In the abbreviated DAPT arm, it was 7.5, and this met the non-inferiority margin. If we look at the major adverse cardiac and cerebral events, we see that in the standard DAPT, it was 5.9%. In the abbreviated DAPT arm, it was 6.1%, and this also met the non-inferiority margin. And after these two endpoints met the non-inferiority margin, the third endpoint was tested, which was the major or clinically relevant non-major bleeding. And here we see significant difference. In the abbreviated DAPT, it was 6.5, whereas in the standard DAPT, it was 9.4%, significant difference. And in this superiority analysis, it did show that the study was, it did indicate superiority. If you look at the secondary endpoints, there was not much difference except some numerical difference, but in BARC 2, there was significant difference. In the standard DAPT, there was a 6.8% of bleeding, whereas in the abbreviated DAPT, it was only 4.5. So like other studies, this study does have some limitations. One limitation being that this was an open label study. The DAPT duration in both arms was longer than what is currently recommended for patients on oral anticoagulants. This study was not designed to assess the role of type of the single antiplatelet after dual antiplatelet discontinuation. And this study, we must remember, may not apply to patients who are not treated with biodegradable polymer sirolimus eluting stents. But in conclusion, the master DAPT study did show that in patients with high bleeding risk who undergo implantation of a biodegradable polymer ultimaster sirolimus eluting stent, the discontinuation of the dual antiplatelet at a median of 34 days compared with continuation of the treatment for a median of 193 days after PCI was non-inferior for the incidence of net adverse clinical events, non-inferior for the incidence of major adverse cardiac or cerebral events, and was associated with a lower incidence of major or clinically relevant non-major bleeding. And this study was recently published also simultaneously with the ESC conference in the New England Journal of Medicine. And I truly believe that this study will impact in future how we treat our high bleeding risk patients and how we prescribe a dual antiplatelet for these patients. Thank you.
So we have quite enough time to discuss. So would you start with Dr. Pham from China? Jiangming Pham. Okay, can you hear me? Any comment or discussion point for?
Thank you, Chairman, for the kind introduction, and it's a great pleasure to be here. I think I'll talk about the master DAPT trial first, since it's just presented. Very interesting results. It's a large all-comer high bleeding risk group involving more than 1,500 patients, showing that 1 month DAPT is enough for patients with high bleeding risk, at least with the Tansei stent, which is the bioresorbable polymer stent, which actually showed that it was non-inferior in terms of ischemic endpoints, while also cutting down the risk of bleed. I think the study investigators planned the trial design really well. It's a relatively complex design. The first 2 clinical endpoints were non-inferior with a net adverse clinical endpoints and the MACE. The net adverse clinical endpoint is like a combined ischemic and bleeding endpoint. The MACE is ischemic endpoint. I think the first 2 non-inferiority endpoints actually allow the investigators to analyze further if there's a strong trend towards a benefit in terms of reduction in bleeding risk. And other previous HBR trials compared different devices. For example, DES with bare metal stents with short DAPT, or short DAPT but with different devices. But they've not really compared short DAPT with longer periods of DAPT using the same device. So I think overall results of the master DAPT trial do give operators some confidence in the use of a Tansei stent in an all-comer population with no restriction in coronary anatomy. And I think the purpose of the trial was actually meant to mimic a real-world scenario to address a practical clinical question facing doctors today: how best to balance the ischemic risk with bleeding risk patients. And I'm glad to say that the trial actually showed that by adopting a abbreviated DAPT regime, we did not see an increase in ischemic endpoints, and there is actually a decrease in bleeding endpoints.
Okay, any comment, Dr. Malik?
Yes, thank you. I think the master DAPT trial really did show us about the fact that even in high bleeding risk patients who come with a pretty, like even in acute coronary syndrome patients, 50% of the study population was acute coronary syndrome patients, but it did not really impact their ischemic risk to the extent. The study showed us that we can afford to abbreviate the DAPT if our patient is truly high bleeding risk. And I think that will make a difference in how we treat our high bleeding risk patients. Because in the previously we were hesitant to treat these patients, and there was always in the back of our minds the uncertainty of how these patients would respond to a prolonged DAPT, and if we had to shorten our DAPT, would we be compromising our patient's safety? But this study showed us that yes, we can safely, at least when we are using the Ultimaster biodegradable polymer stent, we can safely abbreviate the DAPT without compromising the safety of our patients, which is very reassuring for a clinician.
Okay, great. Dr. Yoon Kyung Jo, is there any?
Yeah.
discussion point.
Thank you for lecture. The two studies show the good efficacy and the safety of Ultimate stent. But I have one question to Dr. Kang. In your iris registry, the pattern of the antiplatelet therapy was interesting to me because the Ultimate stent group used the higher instance of the potent antiplatelet therapy, such as prasugrel or ticagrelor. So after matching, the difference was still exist. So I think the use of the potent antiplatelet therapy can affect the clinical event. So how do you think about that?
Thank you for your excellent question. That's a very good point of that shows current pattern of the antiplatelet therapy in Korea after PCI. As you pointed out, the Ultimaster group patients showed higher rate of the potent P2Y12 inhibitor use, like ticagrelor or prasugrel. And there can be some reason of the higher rate of the potent P2Y12 inhibitor use. One would be the higher rate of the ACS, acute coronary syndrome patient in Ultimaster group, because as I talked in the lecture, the higher rate of the patient in IRIS Ultimaster real-world registry patients were enrolled compared with the DPES group. So the more patients with the acute myocardial infarction patient would use the potent P2Y12 inhibitor. And another cause would be the IRIS Ultimaster patient was more recently enrolled compared with the DPES group. There is some gap in time, so it would reflect the more frequent use of the potent P2Y12 emitter use in the current era. That would be the cause of the difference in different pattern of the P2Y12 inhibitor use. And that can be affect the result of the clinical outcome, but the important thing is that in real world practice with the potent P2Y12 inhibitor use, Ultimaster stent showed excellent clinical outcome after PCI in ACX patient.
Okay, Dr. Sunguk, please, Suzu, comment on that. Any other point, your practical point of what is merit of Ultimasters in compared to the other drug stent, etc. for the data? Could you discuss about that one?
Thank you, Chairman and Naik, an excellent presentation. I also have question with Dr. Doim Khan. And your IRIS study presentation, I concern about the baseline characteristics of two groups. Polymer durable polymer giants group has more chronic kidney disease and multivessel disease and IVUS examination. Also, left main involvement is also higher compared to Ultimaster group. And even though the propensity match is, the two group is even, but I am concerned about the uneven condition of between two compared group. What do you think about this baseline characteristics?
Yes, I fully agree with your opinion. There is some significant difference in baseline characteristics, and that would be some regions because this is more national and multi-center, more than 15 centers enroll the patient, and there can be some difference when implanting stent in the many hospitals. We cannot exactly know the region, but I think that the result of the baseline characteristics and the stent used in the patient characteristics shows the current practice pattern in Korea and real world. And in propensity score matching, still there can be unadjusted difference in baseline characteristics. I fully agree with your opinion. And so I concluded that the Ultimaster shows comparable efficacy when compared with the previous or well-proven stent. And the the purpose of this study is to show the real-world safety and efficacy and real-world practice pattern in a current practice in Korea.
Thank you.
Great, great. Actually, the IRIS registry data is just the registries. Reflect of a real world is, however, skewed, the clinical characteristics. So even after any statistical, match issues, and so anyway, we can clearly see that the efficacy concern is quite, equivalent with the other drug stand, right? So would you, some Dr. Yoongyong, would you, describe his detailed product specification of Ultima, stand? What is the, advantages? What's the difference, compared to the current drug stand? Would you define that once?
As you know that the design of the Ultima stage is so interactive for me because the cell size has the good expandability. So if I think the bifurcation is good candidate for Ultima stent. Also, it has the good deliverability. So in routine practice with higher instance of complexity region, the Ultima has several advantages for me.
Dr. Gang?
Yeah, that is very important point because it has very good expandability, especially for the cell size, and it will be very good candidate for the bifurcation stenting during the two-stent technique. So we are also performing some registry study for the left main stenting with the Ultima stent, and maybe we can give more data and next year TCTAP with the left main stenting. Also with the good, very good, excellent data with the master DAPT trial, when we meet the patient with a high bleeding risk, Ultima stent can be a very good candidate.
Okay. What about Dr. Lee? Okay, so Lee, would you like Ultima stent?
No, actually, I participated the IRIS master study. So I already enrolled the patient to your study, and I have some experience of the good deliverability and good actual power, access power, and then especially the stent have the bifurcation region for the not compromising the side branching because the spatial stent design, strut design. So but Ultima study is not inferior, even superior compared to current other drug-eluting stent, I think.
Great. Dr. Pham, any practical, point of Ultima stent?
I think that the fact that the stent has a bioresorbable polymer also has the potential for decreasing the risk of permanent polymer stent related late complications, such as stent peristrut inflammation, risk of late malapposition. I think for practical tip wise, I think the use of intravascular imaging would also further enhance the clinical results of using the Ultima stent.
Great. Dr. Malik, you want to do some comment for the Ultima stent practical point of view?
Thank you. Actually, most of the points have already been alluded to, but I find the Ultima stent really well when there is a mismatch in a bifurcation lesion, where there's a mismatch between the proximal vessel and the distal vessel, because here you can really expand the vessel, the stent properly. So you choose a stent with the size according to the distal vessel. Even if it's of a very small size, you can safely expand the stent to the larger proximal vessel because the expansion capacity is really phenomenal. And also, as has been alluded, I find that the side branch accessibility is great, and rewiring the side branch is never a problem. And usually side branch loss is also very minimal. And also for austere left mains, it has great radial strength. So it's good for left main, osteal lesions or even any tight osteal lesion, it works very well. So I think it's a great stent for deliverability, for side branch accessibility, and also for the expansion capacity, which allows it to be expanded to a much larger proximal branch if the distal branch is very small or narrow.
Great, great. All right. So this is a Terumo session. I have to, I want to do some summary of product specifications. As you mentioned, you all mentioned about the open cell design, very thin strut, and drug itself is sirolimus, and very large size range opening. So we're going to use more, bifurcations and et cetera, et cetera. And also this is abdominal side bioabsorbable polymer. And so that may be related with abbreviated DAPT. 1 month DAPT is quite enough, even in the high, breathing risk patient. And so I think a master DAPT study is really important, issues in the current drug stand status. And so efficacy concern is quite, equipoise with the current drug stand. And we have multi-master has a strong advantage as a, very short-term duration of DAPT for the high breathing risk patient. So, all right, I'm very happy, and I would like to thank again you all for joining this satellite symposium. So thank you again, and so we're gonna meet maybe next year, so face to face, more hot discussion and more hot, presentation. Thank you.
Thank
See you
you.
next
Thank
time.
you.
Thanks so
Bye.
much.